Hi, I'm Dr. Stuart Isaacson, Director of the Parkinson's Disease and Movement Disorders Center of Boca Raton in Boca Raton, Florida. And thank you for joining us for this CME program, Managing Motor Complications in Parkinson's Disease, evaluating the role of on-demand therapies for off episodes. Parkinson's disease is very common. It's the second most common neurodegenerative disorder of aging. And nearly 10 million people globally are living with Parkinson's disease, probably over a million in the US alone. A number of studies have suggested that there may be an increasing incidence of Parkinson's disease around the world, perhaps related to the aging populations, increasing life expectancy, perhaps environmental factors as well. The motor symptoms of Parkinson's disease include the cardinal symptoms of rest tremor, bradykinesia, cogwheel rigidity, and later postural instability. Some patients may develop problems with walking and balance and require assistance. Non-motor symptoms are also common, including depression, anxiety, sleep disorders, loss of smell, and GI dysmotility. Levodopa, of course, is the cornerstone therapy for treating Parkinson's disease motor symptoms. Levodopa is effective robustly often and is something that all of our patients will take at some point in time. When we think about the response of our patients to levodopa, in the initial few years of taking levodopa, the response is very consistent. It remains within a clinical window. It doesn't exceed a threshold to create peak dyskinesia, nor does it typically fall below a threshold to lose benefit clinically and to have an off episode. But somewhere within the first year or 2 or 3, some patients 5 or 6 years if they're lucky, off episodes emerge. The clinical window narrows. There may be some mild peak dose dyskinesia, and the benefit of a levodopa dose is no longer present after several hours, and the symptoms, both motor and non-motor, occur. As the disease progresses, this window becomes more narrow, and patients begin to spend less and less time in a good on state, an on state without troublesome dyskinesia, and more time with the benefit of a levodopa dose being lost and off episodes occurring, or they have too much response and have peak dose dyskinesias that can become troublesome and impact their daily activities. People should be aware that these off episodes can occur at different patterns and different times of the day. The wearing off at the end of a levodopa dose, a wearing off overnight with nocturnal or morning off. There could be a delayed onset of a levodopa dose, a dose failure. Let's hear now from a person living with Parkinson's disease.
But what happened was that I was diagnosed about 13 years ago. For 10 years out of 13, I was fine. I mean, if I this is normal. I mean, it's like nothing was different in my life than I just had Parkinson's. I didn't even tell people. And if I took my medication, nobody knew. And if I met somebody, I didn't need to tell them because I didn't have any symptoms. So in 10 years, I started having had to take more carbidopa, and people don't understand. The reason Parkinson's is an ugly condition is because it robs your life every day, just a little bit of your life. It does, it's not like you're gonna go and like this. So it takes a little bit of your life every day. This friend of mine, towards the end of the day, I really have a lot of problem because I've gone through the day and taken my medication and tried to take it on time and be careful of what I eat and watch what I'm doing. And towards the end of the day, I have this. It just throws my whole system is out of whack, and I'll go off and on and off and on, and it's like no time period. It's like it just gets. I could be on for an hour and then go off for a while, and then go back on and go off. So this friend of mine, we go out to dinner for our birthdays, and every year on my birthday we'll go out. She'll buy dinner, and we go out. I'll buy dinner for her birthday. And she said, where are we going to go? Because my birthday was last Saturday. And I said, to tell you the truth, I really don't want to go to dinner. To go sit in a restaurant at 7 o'clock at night, my system is not malfunctioning. It's not working right.
The reason that it's so important to pay attention to these off episodes is that they can really impact our patients' daily lives. We know from one study that they affect quality of life, both end of dose wearing off, early morning off, nocturnal off, and other fluctuations can significantly worsen quality of life. We also know that they can make our patients hesitant to leave the home during certain times of the day to go on with their daily activities, to exercise, to shop, to make it to physical therapy and other medical appointments. So I think it's very important for our patients as they travel their journey of their Parkinson's disease to be aware that when symptoms occur throughout the day, that these are times when there's not benefit from levodopa, and we should try harder to try to adjust the treatment regimen to minimize the number and degree of severity of off episodes. So there are a number of different communication challenges that may hinder our assessment and hence our ability to choose the right treatment for off episodes. We know that in a short visit that occurs, sometimes it may be hard for all the information to be discussed. Some patients may come with notes that can facilitate discussions, while others may rely on memory, and there may be difficulty remembering all the details of the off episodes, how frequently they occur, and how severe they might be. Some of our patients may lack awareness and education of off episodes, and there may be miscommunication during a visit based on terminology and the lexicon of how we use to describe when the medication is working in an on state and when the medication benefit is no longer present in an off episode. There may also be an attitude among both clinicians, patients, families, and caregivers that most of the day is good, and not to dwell on parts of the day when the medication is not doing as well. There may be hesitancy to talk about off episodes for fear of having the medications increased, or fear of having medications increased and developing dyskinesia or other side effects. There may be a feeling that by having medications addressed and increased, that it might lead to one feeling their Parkinson's is worse. There are some approaches that may promote better communication surrounding off episodes, engaging our patients in education about Parkinson's disease, its progression, the pathogenesis of off episodes, and the numerous treatment options that have become available in recent years. Letting our patients understand that the evaluation can help define a better treatment regimen that might be able to help them. We should have our patients think about the evaluation of each levodopa dose and their response to it, both beneficial and any adverse effects that might occur. We should talk about off episodes at each visit so that our patients and their families and their caregivers become used to talking and recognizing the symptoms that occur as not being necessarily a worsening of their underlying Parkinson's disease, but a reflection on how the levodopa response is no longer continuous in its benefit and interrupted by off episodes. Sometimes we can think about utilizing diaries or questionnaires or giving sheets that patients can keep notes on. Sometimes we want to know very specifics, and sometimes we're more interested in knowing about patterns. Each patient is different. And in this era of personalized medicine, it's helpful to include our patients in a shared clinical decision making where they can help define what their problems are when the off episodes occur and help choose which treatments will be best to try to reduce off episodes. Some of these areas of communication have been difficult in the past year with COVID, reducing the face-to-face interactions. Some of our patients have not come to visits as readily because of COVID, and some have been affected by COVID, either personally or in their families. So we now have to begin again in trying to rethink how we communicate with our patients post-COVID in trying to understand their current responses to medication and when off episodes are affecting their daily lives. We've begun to use technology to understand off episodes as well. Smartphone apps can help patients keep track of their symptoms. They can keep notes on their phones and devices of when off episodes occur and how long they last. Some of the apps can measure when they're having tremor, or they can do tapping or other types of tests to see if they're having slower movements. There are wearables patients can wear. A number of these are available now and have been used in patients to try to understand throughout the day when there are periods of bradykinesia and periods of tremor and other periods when there's a good on response. So I think with this new era of technology, we're really going to be able to understand how our patients respond to levodopa, how long a dose might last and how long off episodes last when they recur throughout the day. And also begin to understand how often off episodes occur just once or twice a day or 3 or 4 times a day, and how some days are different and better and other days are worse. I think our patients have been telling us this for some time, and we're seeing this objectively now with these wearables and apps. Let's turn again to our patient with Parkinson's disease.
So listen to your doctor, but have a trust in your doctor, and make him show him that you're interested and that you care. Okay, I think that's very, very important. And if you have a caretaker, make sure the caretaker goes with you. I don't personally, so it's a little more difficult for me. But what I actually do in place of that is I do some videos. Like if I just so happened the other day by accident, I went off my medication. So what I did is I took my phone to my neighbor's house and I had him do a video of me walking, and it showed that I had a lot of dyskinesia, where my hand was back behind my flat out like this, and what I'm doing now is this involuntary movement, and also too I'm having problems with losing my balance off of medication. So he took a video, and a lot of times you show the doctor that, and he'll say, I didn't know that. My doctor is a very well regarded movement disorder specialist in the world. And one time I took him a video and he was shocked. He said, I don't believe that's you. So if you have a certain issue, take a video of it. That's what you have cameras for today. I mean, I have problems with dystonia in my feet. So a lot of times when I have a dystonia, my toes are curling really bad. I will take a video of it to show my doctor. For Parkinson's, besides the video, is to keep a diary. I mean, and if you do a clinical trial, you'll have to do that. And it's not like you have to carry this diary around with you, but if you show the doctor something, he doesn't have anything to see. You don't see him every 6 months. So if you do a clinical trial, you'll learn about diaries. It'll have the date, and it'll tell you the time you took your medication, time you were on, time you're off, with troublesome dyskinesia, without dyskinesia, and it gives him something to look at. You listen. You go into that, like my example here in Atlanta. I have to drive 50 miles. It's 50 miles to Emory. Okay. So, and I have to go into Atlanta and then up to go out of Atlanta to go there. So it's not exactly the easiest thing to do. So I'm not going to go there off. And then, like I say, I go back to the thing is, who would go to the doctor when you're not in the best shape? So you're going to be at your best, and the doctor say, well, how you feeling? You're not going to say, I feel like I'm dying tomorrow. So for some reason, we feel like we have to put on a good impression to a doctor, and not, actually not tell the total truth. So I think it's very important that you show him that, because he doesn't know. He's not with you 24 hours a day, and that with this diary, and keeping track, he can look at something. Then he's got something to, because everything is, unless you show him that or a video, everything's a guess. I personally like telemedicine. I think it's great because you can, your doctor's in a room in his office, doors closed, nobody's bothering him, and you can talk to him down to earth. It's just, I think telemedicine is wonderful. When you go to the clinic, you're in their house, the doctor's house. When you go to telemedicine, you're together in one place. It's not like you're in his house or he's in your house. And you can be honest with him. He's in that room. It's so comfortable. Let's face it, you don't have to get dressed up. I mean, like we were joking earlier, this pandemic, it's going to be odd to wear a pair of pants that actually have a button instead of a drawstring, and you don't have to get dressed up. You can be honest. You could actually see, if you were home and you had the problem, you're going to telemedicine, you could show him. You don't have to show a video camera with your phone. There's just a lot of things because movement disorder especially has to do with too much stuff from guessing.
We have a number of different treatment strategies for our patients who develop off episodes in Parkinson's disease. We, of course, can adjust carbidopa levodopa. We can change the timing of doses, moving them closer together. We can raise the dose or do both. We can change carbidopa levodopa immediate release formulation to a longer acting formulation. Recently, we've had an extended release capsule that contains different beads of carbidopa levodopa that are released at different times in the intestine and provide a 4 to 5 hour plasma levels. The problem, though, is that the oral carbidopa levodopa has to be swallowed. It has to traverse the esophagus, which has dysmotility in Parkinson's, to enter the stomach, which has a gastroparesis and a delayed emptying. It may sit there, a dose of carbidopa levodopa, for 10 minutes or for an hour and 10 minutes. And all this time, it cannot have any clinical benefit until it dissolves and leaves the stomach and enters the small intestine where the large neutral amino acid transporter is present. And another problem that we have is that many of our patients find one dose works quickly and another dose is delayed. It may be delayed not only by gastric emptying difficulties, but by the presence of dietary protein. The response to individual doses can be very, very variable, regardless of whether the medication is taken in the fed or the fasted state. Indeed, some doses are swallowed and enter the plasma within 10 or 20 minutes, whereas other doses may stay outside of the plasma for 40 or 60 or 90 minutes. This extreme variability, regardless of taking oral levodopa in the fed or fasted state, is really a great problem for many of our patients, and each dose may be variable. We may use adjunctive therapies in combination with carbidopa levodopa to treat off episodes as well. Inhibitors of enzymes involved in the metabolism of dopamine and levodopa can be helpful. MAO-B inhibitors are available, which can reduce the metabolism of dopamine in the striatum, extending the presence of dopamine in the striatum. COMT inhibitors are available as well, and these tend to work peripherally to reduce the metabolism of levodopa, allowing more of it to be transported across the blood-brain barrier and be converted to dopamine in the brain. Dopamine agonists don't become dopamine, but mimic dopamine. Both oral, transdermal, and extended release oral formulations are available of these medications. These can be helpful when added to the current regimen of carbidopa levodopa to reduce off time as well. And more recently, we've had non-dopaminergic adjunctive therapies become available that work as antagonists at the adenosine 2A receptor or at the NMDA glutamatergic receptor. Many of these adjunctive therapies, though, have limited utility in improving off time. While differences from placebo and randomized blinded trials are significant statistically, they tend to add 1 to 2 hours more on time and less off time in a day when added to a current regimen of stable carbidopa levodopa. We often still have off time that remains, and in many studies, this has been as up to 6 hours of off time. I think with the new era of wearables, we'll be able to measure this better in our patients. And as patients come to routine clinic visits and we find that they're spending only half of their waking day in a good on state, it'll give us an impetus to think about new treatment options for our patients. For some of our patients, advanced interventions are used. In the US, we have subcutaneous delivery pumps in phase 3 trials that deliver either the dopamine agonist apomorphine or a liquid formulation of carbidopa levodopa. We also have a continuous levodopa carbidopa intestinal gel that's delivered through a pump through a PEG tube in the stomach with an extension to deliver this gel directly into the intestine, bypassing the GI dysmotility of gastroparesis. And some of our patients resort to deep brain stimulation surgery to improve their off time. And more recently, we've had on-demand therapies. Let's turn and think a bit more about on-demand therapies. For very long, there was an unmet need where patients who were in an off episode would swallow oral levodopa and it would take too long to work and they would remain in that off episode. It's led to a thinking that we need non-oral therapies to use in these patients who have a variable onset of levodopa effect different days. These so-called on-demand or as-needed therapies have now become available commercially. In 2004, we had the approval of a non-oral therapy to treat off episodes of apomorphine, a dopamine agonist that was injected subcutaneously with a pen-like device. In 2018, we had the approval of a levodopa powder formulation that's orally inhaled. And in 2020, we had the approval of an apomorphine film that's placed beneath the tongue and absorbed submucosally.
Let's hear from John about his experience with on-demand therapies.
Myself personally, I've always thought they tried to hit a 4-hour window when between doses of medication. Okay, and I was in a 4-hour window, and I was taking, this is probably, I don't know, out of 13 years, 8 years into being diagnosed, I was taking 2 pills every 4 hours. And, it'd be like, say at 6 o'clock in the morning, I'd start here and go up, and then you'd hit the peak like at 10 or at 8. And then come down, and you'd be at 10 o'clock, you need your new medication. And when those times become tighter in between, and there's that open time, that's when the rescue medication would be helpful. The biggest problem I have as time goes on, you wouldn't have, like I say, it wouldn't be a wave pattern. It'd be like jumping off a cliff. And so that the rescue medication, to me, helped me overcome that of going off a cliff, because once you went straight down, it was harder to get back up, you see. So the rescue medication helped even that wave out, personally.
Let's turn now to an on-demand therapy that uses levodopa. Using ARCUS technology, the levodopa molecule was expanded and could be used for inhalation through a plastic device that is placed in front of the mouth, and patients breathe in oral levodopa in this formulation. Orally inhaled levodopa can be administered up to 5 times a day. It's available in capsules, and 2 capsules make a full dose, each capsule containing 42 milligrams, and the 2 together 84 milligrams, which is comparable to about half of a carbidopa levodopa 25-100. It doesn't enter the GI tract, but rather enters the lungs, is transferred through the alveoli directly into the bloodstream, and can reach plasma levels very, very rapidly. In clinical trials, we saw an improvement after 10 minutes, increasing over 30 minutes. And this led to a significant improvement over placebo at 30 minutes. This seemed well tolerated and safe, including in long-term pulmonary studies. The most common adverse events included a cough, which may be less if we try to instruct our patients to breathe in more gently. Also seen were upper respiratory tract infections, nausea, and discolored sputum from oxidation, perhaps, of residual powder, which can be addressed by rinsing the mouth after use. Orally inhaled levodopa is contraindicated in patients on non-selective MAO inhibitors and patients who take dopamine antagonists, such as antipsychotic drugs or certain antiemetics. It may also interfere with the use of levodopa, of course. Let's turn now to another on-demand therapy, apomorphine. Subcutaneously injected apomorphine has been available in the United States since 2004. Apomorphine is a dopamine agonist that has a dopamine-like effect in its receptor affinities to the D1 and D2-like receptors. Subcutaneous apomorphine injection can be used up to 5 times a day. It comes in a pen-like device that contains a cartridge, and that cartridge contains multiple doses that can be injected. The dose ranges between 1 and 6 milligrams at each dose and has to be optimally titrated to find the dose that works as well as a patient's levodopa dose. The subcutaneous PET injection of apomorphine usually results in onset of action within 10 minutes and a full response by 20 minutes. Once it begins to work, the effect lasts approximately 60 minutes, perhaps a bit more, enough time for the next oral dose of levodopa to be taken. The response to apomorphine is robust and is the only medication that has as robust benefit as levodopa. Common side effects seen with the use of subcutaneous apomorphine injection include nausea, sleepiness, dizziness, and orthostatic hypotension. Nodules can occur in the subcutaneous space as well. It is recommended to treat pre-dose with an antiemetic, trimethylbenzamide, to try to reduce the incidence of nausea and orthostatic hypotension. Subcutaneous apomorphine injection is contraindicated in patients who use an antiemetic that works at the 5-HT3 receptor as an antagonist. More recently, another formulation of apomorphine has become available. This sublingual film containing apomorphine can be placed beneath the tongue and be absorbed through the mucosa. The sublingual strip is in individual pouches, and these pouches can be opened when needed to treat an off episode, up to 5 episodes each day. In the clinical trials leading to its approval, sublingual apomorphine was titrated from 10 milligrams to 30 milligrams in 5 milligram increments to find the dose that worked as well as their levodopa to produce a full-on response, and to do so within 30 or 45 minutes. In these studies, we could see an improvement within 15 minutes after placing the sublingual strip beneath the tongue, with the full-on identified at 30 minutes in many patients. The on duration lasted out to 90 minutes, the last time point evaluated, with a significant improvement compared to placebo. Adverse events were similar to apomorphine subcutaneous, including nausea, sleepiness, dizziness, orthostatic hypotension. Also seen with the sublingual formulation were oropharyngeal reactions with erythema or swelling. Patients who develop oropharyngeal reactions may need to stop the use of sublingual apomorphine. It is recommended to use an antiemetic due to the incidence of nausea and orthostatic hypotension in the label. Sublingual apomorphine is contraindicated with the use of antiemetics that have action at the 5-HT3 receptor as antagonists. It is important for patients to be educated on how to use sublingual apomorphine, that it should be open just prior to use and the film placed beneath the tongue lowered, the mouth should be closed, and patients should be instructed not to talk or swallow for 3 minutes so that the apomorphine can be adequately absorbed. As well, patients can be encouraged to moisten the mouth prior to use, and after 3 minutes, they can rinse their mouths so as not to leave a film residue beneath the tongue. Now that we have a new era of having on-demand therapies for our patients who have delayed onset of medications and a new way to treat their off episodes, it's really an era now that will empower our patients to hopefully better recognize off episodes when they occur and to treat them by taking something that they carry around with them, either an inhaler, an injection pen, or a sublingual strip in this pouch that they can use up to 5 times a day to treat their own off episodes when they occur. All these on-demand therapies demonstrated efficacy in a more rapid onset than oral levodopa, improving off symptoms within 10 or 15 minutes, with significant improvement by 30 minutes. So as we think about how we view the multitude of adjunctive therapies that help us treat our patients with Parkinson's disease who have off episodes on carbidopa, levodopa, and this new era of having several new on-demand therapies that can be used as needed to provide a non-oral option for our patients to empower them to recognize and treat up to 5 times a day their off episodes. It's important to think about how each of our patients are different, and we have to personalize and individualize our treatment approaches for each patient. Our patients have different ages. Some people of younger age or are still working may need a therapy that will allow them to continue on with their working days. Others may not be working or may need just as important ability to turn back on in the middle of exercise or playing golf or tennis, or they may be traveling to see their families or children or grandchildren or great-grandchildren. Some of our patients have had Parkinson's disease for more than a decade or approaching 2 decades. Some may be in the first 5 or 6 years. Some may recognize their symptoms as occurring at the beginning of an off episode, and others may not recognize their symptoms till they're more severe in an off episode. Some may recognize both motor and non-motor symptoms of off episodes. Some may have to contend not only with off episodes at the lows, but dyskinesias at the peak. Some of our patients can recognize that off episodes occur predictably at the end of some doses or many doses. Others may recognize the unexpected off episode that disrupts their day. Some of our patients have comorbidities that may influence which medications we can treat them with. It may be dyskinesia or hallucinations or orthostatic hypotension that's symptomatic. So our patients may have impaired cognitive status that can impede their treatment as well. And we have to think about each individual therapy that's available, its efficacy, its formulation, its safety, and tolerability. Some patients may seek new therapies to try to treat their off episodes and use them readily. Other patients may be reticent to try a new medication or to add another medication to their medication list that already they feel is too long. Some of our patients may have off episodes that don't impact their days and don't need to be treated. And others may have off episodes that impact their days, but they don't recognize that it's an off episode. And they think it's just their Parkinson's getting worse and there's nothing that can be done about it. Trying to put together the frequency, the severity, the variability, the timing, the types, and the impact of off episodes can really expand the communication we have at our visits with our patients, their families, and their caregivers, and enable a truly informed shared clinical decision making so that we can choose not only whether and how to adjust their carbidopa levodopa dosing, choose whether to add or change or increase or stop adjunctive medications, and importantly now, to decide which of the on-demand therapies our patients should be prescribed so that they can be empowered to recognize and to importantly treat their off episodes to more rapidly and reliably return to an on state and go on with their days. I hope you found this CME program helpful and educational, and I thank you for joining us.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.